Good afternoon. Thanks for joining us today. I'm Mike Bromersky, Superintendent of the Hempfield School District, and on behalf of all of my superintendent colleagues across the county, thank you for joining us for this webinar on COVID-19 vaccination and variations. We are extremely grateful for Dr. Martins, who's joining us today, for the time and effort that he has given us through the course of this school year, and as well as the partnership we've generated with Penn Medicine, Lancaster General Health. And that partnership has allowed us to open our schools safely and continue getting medical support, guidance, and expertise as we've navigated COVID-19 in our schools. The partnership was made possible by federal dollars that our county commissioners allocated on behalf of all the school districts. So we're very grateful for their support as well. So today's webinar is COVID-19 vaccination variations, presented by Dr. Jeff Martin, who's the chair of the Department of Family and Community Medicine, as well as the medical director for Lancaster County's contact tracing program. So thank you for joining us, and Dr. Martin, I'll turn it over to you.
Thank you, Mike, and good afternoon, everybody. It's nice to be with you again. And as per usual, we'll be trying to, I'll talk for about maybe 25 to 30 minutes, and then hopefully we'll have a good time for questions. So what I'd like to start out with is just a brief status update about the pandemic. I usually can't give any of these talks until we sort of review what the current state is. We'll talk about the COVID-19 vaccines again, how they work, the myths about the vaccine, with basically looking mostly at the JNJ vaccine. We'll talk about the variant strains of COVID. We'll give an update on vaccine distribution, and then hopefully have time for questions. But before I do any of that, I'd like to just pause and recognize that it's been a year since COVID has hit our community. And I've been quite reflective about this, grateful actually, in where we were back in last mid-March, where we are now, the partnerships that we've developed, as Mike has said, both with the health system and the community and other health systems and other providers in the county. I really don't think we could have gotten through this pandemic as well as we have without those relationships. So although in mid-March I had no idea what my life would be like over the succeeding year, I'm sure that resonates with probably everybody else on this call. I feel grateful that we've come through, and we're starting to see increasing light at the end of that tunnel. And certainly we can actually start to kind of think about months ahead in which things will reach some sort of normalcy. So I just wanted to mark that significant anniversary. So in the past 7 days, over the last week, COVID cases in Lancaster County have dropped a bit, not a whole lot, only about 7, down a little less than 100 cases from the week prior, but it is a decrease in cases nonetheless. Our incidence rate continues to be fairly high. We are in the highest category right now, or continue to be in the highest category of community spread, although our incidence rate currently of 122 is down significantly from where we were at the peak back in mid-January, which was in the 400 range. But we are still significantly higher than we were at the peak of the first surge of this pandemic. And so I think we need to continue to realize that. We've had several weeks of decreasing cases and a decreasing incidence. However, about 2-3 weeks ago, we started to plateau. And so we're not seeing as big a drops as we were seeing week to week previous to that. And I think there's some reasons to why that's happening, and I will go over some of that. Deaths continue to be lower, except last week there was 11 deaths compared to 10 the week before. It's interesting because we actually did see a little uptick also in hospitalizations over the past 2 weeks from where we were. More hospitalizations obviously are going to mean more deaths. The hope is that as cases continue to drop, deaths will also continue to drop, although it's a lagging metric and it may not drop for 2 to 3 weeks after cases go down. The percent positivity didn't change much from last week from the week prior. It stayed steady at 6.1%. And then when you look at the percent positivity of the tests that we do here in our system at LG Health, there's actually a bit of an uptick in the percent positivity. So a little bit of a mixed bag. And we would like to continue to see the percent positivity drop. We'd like to see it below 5, but ideally below 3 would be great. And so hopefully we can get there in the next several weeks. But we'll have to kind of wait and see. The turnaround times for testing continue to be quite good. We are getting tests back within less than 24 hours. This is really important when it comes to contact tracing and reaching out to people to quarantine them because time is of the essence. And the quicker we can get somebody isolated who has COVID or in quarantine who's been exposed to somebody with COVID, the decrease in community spread will have. So our testing seems to be quite good. So I put all these metrics together on one graph. Actually, our epidemiologist here at the hospital has done this for me. And I marked the line there at the start of the third surge in early November. What I want you to take a look at is the gray line. So the gray line is the number of cases, and we've really had this big peak right around mid-December, and then again in mid-January, sort of a sawtooth pattern, up and down, up and down. And since that time, we've dropped, but really have kind of plateaued here since the end of February, the beginning of March. Now, if you take this gray line on the right-hand side of the graph and you trace back to where the gray line was during the first surge, we're about double the number of cases in that first surge. And remember how we all felt during that time. There was lockdown orders, there was much concern. And I still think there should be much concern, but it appears that our community in a lot of ways has sort of seen this decrease in cases and said, it's over. Well, it's not over by any stretch of the imagination. And I just want us to remember that we're double still where we were at the peak of the first surge back in April of last year. The yellow line is the all-important R value that has consistently been low, but again has been rising here since the beginning of March. And that concerns me because when the R value goes above 1, we start to get an increase in cases, which means more cases will mean more hospitalizations. More hospitalizations generally mean more deaths. And that's kind of how the indicators follow each other in a stepwise fashion. So let's take a look at that R value. I want you to focus just on the orange line. So again, anything above 1 means cases are increasing in the community. Anything below 1 means the cases are decreasing. You can see I've marked out the holiday and New Year bump. We had a bunch of data that was put into the system due to an electronic interface that was developed with Patient First. So there was a backlog of data that came in. So that big jump in the R value is an anomaly. It's more related to data. But what we see since mid-February is really a slow decrease in the R value. And I think that represents social distancing. It means that we were scared. People were following the mitigation measures. They were wearing masks. They were limiting travel to non-essential businesses. But since the end of February and going into March here, we're starting to see an increase in that R value. It's not unique to Lancaster County. We're seeing it in Pennsylvania as a whole and also the US as a whole. Although that green line, which is the US, is above 1, we're still just hugging that 1 line. If we stay on 1, it means we really won't have any increase or decrease in cases. It just means we're going to remain flat for some time. But if we double down again on doing better at social distancing, we can drop that line well below 1 and start to see a decrease in cases. So one thing we look at to try to understand how well people are doing in terms of their mitigation measures is we use a metric that looks at travel to non-essential businesses. And this is a metric put out by Children's Hospital of Philadelphia, and it looks at publicly available GPS data, and it can determine where people are traveling to. This metric has been remarkably accurate. The concern I have is that we continue in Lancaster County to not do so well. So looking at this metric over the past 7 days, we're only 3% below baseline, meaning 3% below our travel to non-essential businesses than we were pre-pandemic. So essentially, we have decided somewhat as a community that things should be back to normal, and we are doing all the travel to every non-essential business that we were doing pre-pandemic. The concern there is that's not what's happening in our surrounding counties, although they're starting to look much worse as well. So you can see how we compare to Berks, Chester, Dauphin. The only county surrounding us that we're doing better than at this point is York County, who's only 2% below baseline. So if you model out what our cases will be with this amount of social distancing, it remains flat. And I highlighted that with the red sphere there in the graph. Again, we've modeled that we can do better. We can decrease cases by increasing our social distancing rates, following the mitigation measures, mask wearing, certainly limit family gatherings from separate bubbles. And we certainly can do it again. And I think that's the optimistic message. If, however, we continue to go around in our community as business as usual, we're not going to see a large drop off in cases for a while. And not until we get up to 60, 70, 80% of people vaccinated, which still won't happen for some time. So we can do it. I think we should do it, obviously. And I think we have the power to do it. We just need to do it. So let's talk a little bit about vaccines and variation. So I did this during the first vaccination talk. I think it was helpful, but I wanted to go back to our junior high or high school understanding of how transcription happens in the cell. So under number 1 here, you can see that the DNA in the nucleus of the cell, of course, that's the library that encodes for a certain protein. Through a process called transcription, the DNA breaks open and an RNA template that travels outside the nucleus and into the cell to the ribosome, which is the factory protein factory making part of the cell. And once it leaves the nucleus, it's called messenger RNA because it's going out of the nucleus and into the cytoplasm of the cell. On number 3, you see that the ribosomes then read the messenger RNA. They piece together amino acids that are manufactured separately within the cell through a process called translation, and they end up creating a protein. The protein is the spike protein on the COVID virus, and that's the protein that gets then expressed on the outside part of the cell. It's read by the immune system, and that's how immunity occurs. So as we'll see with the messenger RNA vaccine, we basically skip step 1 and step 2, and we just go right to the messenger RNA, which goes to the ribosome and makes the protein. However, the J&J vaccine pretty much uses all of these steps, just like the cell normally would when exposed to a foreign object like a viral protein. So again, the novel mRNA vaccines, COVID and Pfizer, occur. They reach immunity by injecting a bit of messenger RNA into your muscle cells. It gets taken up by the muscle cell. It's encoded in it's encased in a lipid balloon envelope, if you will. That messenger RNA goes directly to the ribosome. The ribosome makes the spike protein. They get expressed on the surface of the cell, and then the immune system takes over, just like it would if the cell was taking in a coronavirus or COVID-19 virus particle. So that's how it gets the immune system to create immunity without actually having natural infection. So the J&J vaccine works a little bit differently. The way the J&J vaccine works is that it actually uses double-stranded DNA inside of a adenovirus. An adenovirus is a virus that circulates every winter, and it causes common cough and cold symptoms in most people. But they use a type of adenovirus that is what we term replication deficient, meaning that it doesn't replicate itself. It doesn't cause disease. We're just using the adenovirus kind of as a Trojan horse to get the DNA that encodes for that spike protein on the coronavirus into the cell. It's also different than the other vaccines because it's administered as a single dose to those over the age of 18. It is quite safe and highly immunogenic. In the phase 3 trial, which is the trial that determines whether or not the vaccine is efficacious and safe, it enlisted 44,000 participants. It was a very global vaccine, meaning that it was put out at a time when we had a lot of these variants, especially in Brazil and South Africa circulating. It was also put out at a time when there was more UK variant around. And so some people say that this vaccine, because it came later than Moderna and Pfizer, actually is a better vaccine because it was put up against many of the common variants that we're seeing circulating around the world right now. It is 72% efficacious for moderate or severe disease in the US, but 85% against severe disease. And just like the Pfizer and the Moderna vaccine, the J&J vaccine is 100% efficacious against death or dying from COVID-19. The protection against COVID starts about 2 weeks after the vaccine and peaks at 4 weeks. One other benefit of the J&J vaccine is that it is refrigeration stable for 2 years in a regular refrigerator, but it does expire pretty quickly after 2 hours at room temperature. And Johnson & Johnson has promised 100 million doses to the US by the end of June. So this has a lot of, this vaccine has a lot of benefits. It's efficacious, it's a one-shot piece, so going after populations that are going to be very difficult to schedule for a second round of shots. Also in places like rural areas that don't have the cold supply chain that we need for Pfizer and Moderna, this vaccine is probably going to hit the mark. I went ahead and took a look at what the vaccine components are because I know people are quite concerned about what they're injecting in their bodies, and rightly so. The J&J vaccine is a replication incompetent recombinant adenovirus, and that has been grown in a cell culture, which I'll talk about a little bit later. The vaccine also contains the following ingredients: so citric acid, trisodium citrate dihydrate. I'm not going to go through the list of all these, but you can see what their functions are and what the purpose are. They are various stabilizers, they're salts, and they're buffering agents to get the pH right of the vaccine. Many of these chemicals have been found in vaccines, in many vaccinations, and they've been in use for decades. What it doesn't contain, I think that's almost as important as what it does contain. The J&J vaccine does not contain fetal cells, does not contain blood products, does not contain COVID-19 virus. That's very important. There's no way that you can get either adenovirus or COVID-19 virus from this vaccination. It does not contain mercury. It was not grown with eggs. It does not contain latex. There are no pork products, preservatives, or microchips in the vaccination. Now, the J&J vaccine, unlike the Moderna and Pfizer vaccine, the adenovirus was grown in a fetal cell line taken from an elective abortion in the 1980s from the Netherlands. This is a cell line that has been used by science for years and years and years because of its stability and its replicability. And that's how we got the adenovirus that we use as the Trojan horse for the vaccine. It was grown in that because you can't grow viruses without using cell culture. There's some concern about the use of a fetal cell line. I would refer you to the Vatican's doctrinal statement about the J&J vaccine, which they have said without other vaccines being readily available, it is morally acceptable to take the J&J vaccine. I would also like you to think about the moral dilemma that some folks who are pro-life do not want to have anything to do with anything taken from an aborted fetus. I would just say that the vaccine itself is also a pro-life intervention. So it will not only potentially save your life, but potentially those around you. So I think there are enough statements out there to make most people feel comfortable that are either Catholic or have a pro-life stance that the J&J vaccine is still a reasonable alternative to Moderna and Pfizer. So just to picture how this works, you have the adenovirus, which is containing the double-stranded DNA. It comes up against the cell, it gets taken into the cell. The adenovirus breaks down and then injects the DNA into the nucleus. The nucleus makes messenger RNA out of this DNA, which then quickly degrades. So that that double-stranded DNA for the spike protein of the COVID virus does not stick around very long. The messenger RNA gets encoded and it travels into the cytoplasm of the cell. You can see the arrow that I drew up. It goes to the ribosome, it makes a spike protein. The spike proteins get incorporated on the surface of the cell, and that's how the immune response occurs. Side effects of the JNJ vaccine. Generally less than the Moderna and the Pfizer vaccinations. In order of frequency, the most common is fatigue, then headache, myalgia, nausea, and fever. We're not seeing any difference in severe reactions in terms of anaphylaxis, which are very uncommon. Some reported now to be only about 4 to 5 in a million. With the Moderna and Pfizer vaccination. But the side effects are, at least the systemic side effects, are generally a little less harsh, but you can still have them just like you do with the Moderna and the Pfizer vaccination. So there's a nice one-pager that we've put out on our FAQ page that I think would be nice to put up in your workplace or to look at when you're thinking about the different vaccines. Each vaccine really has its pros and cons. None is clearly superior to the other. But the most important thing is that all are 100% effective at preventing death from COVID-19. And that's really where we're at this point. It would be a shame at this point that we continue to have deaths with an effective vaccine. So trying to get shots into arms is really what we need to focus on. Some work better against various variants, but all have some activity against all the variants. So that's what I want to stress as well. So you can't really choose which vaccine you want now based on whatever variant might be circulating in your community. So we know that these vaccines prevent infection, but do they prevent transmission? And we're starting to get a lot more data that yes, indeed they do. So not only do they prevent symptomatic infection, but they also prevent asymptomatic infection or small viral loads that somebody can get where they don't develop symptoms, but can still pass on COVID to another person. So we are seeing pretty significant reductions in this asymptomatic, the possibility of transmission. And the next step really at this point is to look at transmission studies, meaning are people in populations who have been vaccinated not passing on the virus to other people? So that is the next phase. It's going to take a month or two in order to get more data related to these transmission studies. But at least at this point, if you're fully vaccinated, it does appear not only are you safe from getting serious infection, but you're also probably not going to pass this on in any meaningful percentage to other people who are not vaccinated. So let's go over the vaccine myths. These vaccines change your DNA. As I mentioned, they do not. The mRNA vaccines don't even go into the nucleus. And the DNA that does go into the nucleus from the JNJ vaccine is degraded quite rapidly. And it's only used in order to make the messenger RNA template. There is no microchip in it. There are potentially microchips on the boxes that these vaccines come in, so people can keep track of where they're going and the lot number and so forth. These vaccines have not been rushed. The JNJ vaccine and the adenovirus vaccine has been around for decades, just like the messenger RNA vaccine. So these are not newly hatched vaccines. These have been around for a long time. It is really important if you've had COVID to continue to get one of the vaccines. We know that if you've had COVID, you can get a vaccine. Your immunity is quite a bit more boosted in a significant way. It is still very important to wear your mask, especially in public. There have been some reduction in some of the mitigation measures, which I'll go over. The vaccines generally do not have preservatives in them. You can't get COVID from the vaccine. COVID vaccination can cause infertility, has not been proven, or really even a mechanism that I can think of that might cause infertility. COVID vaccine, one myth is that the COVID vaccine can affect the growing fetus. The only way that these vaccines affect the growing fetus is that you create antibodies as you would if you had natural COVID infection. Those antibodies will cross over the placenta into the fetus. So in some ways, you're actually protecting that fetus who otherwise would not be able to get a vaccination once they were born, since we can only go down to age 16 with one of the mRNA vaccines. And I think it's a huge myth that the J&J is an inferior vaccination. In fact, it may be superior because it was circulating and it was tested at a time when many of these worldwide variants were circulating. So let's talk about the variants. The most common strain right now is this D614G strain. Other variants that are cropping up, of course, are the UK variant. That's been shown not to be resistant to current vaccines. The South African variant, which is much lower, but we are still seeing it in the a few places in the US. It does show that it may be resistant to the monoclonal antibody treatments. And there have been some lower antibody titers to the messenger RNA vaccines have been described with that one. The Brazilian variant, we are not 100% sure how well the vaccines do with it, and we're studying that currently. There's some other local variants in California and Ohio. The CDC has some nice websites if you're interested in tracking all this, but the UK variant by far is the one that is getting most buzz. It is in almost every state in the union at this point. PA has had 56 identified cases, but you can see California, Michigan, and Florida are really the places that are hardest hit with the UK variant. It appears that the UK variant is probably going to become the predominant variant circulating. And even though we've seen quite a bit number of cases, we're continuing to see the UK variant increase exponentially. So it's entirely possible that over the next several months, the UK variant becomes the most common variant that's circulating in the US. The South African variant, PA has only had one case. Again, not many cases in the US at this point. And then even lower on the list was the Brazilian variant. So I'm sorry, the South African variant has one case. The Brazilian variant is even lower on the list. PA has not had a case of the Brazilian variant as of yet. So how is vaccine efficacy? The Pfizer vaccine has been shown to be active against the UK and South African variants. Moderna is been shown to be active against the UK variant, and there are some reduction in neutralizing antibodies to the South African variant, but the study still showed that there was protection. Johnson & Johnson has actual on-the-ground vaccine efficacy against all the variants, and as I mentioned, for all regions, 85% against severe disease. So what's happening with vaccine distribution? So just as a reminder, we are in phase 1A currently. Schools were in the 1B category. However, they've been prioritized now for the Johnson & Johnson vaccine. The 1A category is quite large because Pennsylvania decided to add a lot of other people to that 1A category, including persons ages 65 and older and persons age 16 to 64 with high-risk conditions. However, the state did come out recognizing that schools are very important to our communities, to our societies. They are essential workers, and so they are prioritizing schools with the J&J vaccine. And this is administered through a partnership with IU13, the PA National Guard, and AMI, which is the testing agency that has been doing COVID testing in various counties. So where are we at? I highlighted Lancaster's vaccine distribution so far. We have at least partially vaccinated at least 88,000 individuals. That's pretty good for a county. Our county has a population of 550,000. So we are continuing to see steady uptake in the number of partial and fully vaccinated people in Lancaster County. The Vaccinate Lancaster Community Vaccination Center has opened up. We've almost registered about 75,000 people. 12,000, over 12,000, nearly 13,000 have been invited, and we've administered almost 5,000 shots so far. We're currently giving Moderna and Pfizer at the Community Vaccination Center at the old Bonton. We do have about 10,000 doses of both Moderna and Pfizer shipped for this week, with the possibility of more. Our hope is to continue to ramp up the number of doses, because we can give at this site up to 5,000 to 6,000 shots per day. We have been actively planning for vulnerable populations. So we have been giving pop-up vaccination clinics at various locations, at community meals, at some of the housing projects downtown. We're working actively with a multitude of stakeholders, faith groups, to reach vulnerable populations in high-risk areas, and that will continue. We won't all push all the vaccination out to this site. We're going to definitely need to go into the community to reach people. So what does the future hold? So we're starting to see less cases due to a combination of immunization and natural immunity. So if you assume that our population in Lancaster County has 550,000, the number of persons with at least some vaccine is 88,000. The total known cases is just shy of 41,000. The CDC says that for every case that you find, there's probably 4 cases or so that go undetected. So if you take that 40,000, you times it by 4, that means that we probably had about 163,200 cases of COVID in our community. You add this all up, it means about 46% of our population has some immunity so far to COVID, which sounds great. And it is great. And I think that's in part why some of the cases have dropped off so dramatically. However, we plateaued because 46% is not nearly enough where we need to be. In fact, if you model this out over the next 100 to 200 days or so, and we hold steady and we don't continue to quickly vaccinate more people, we're going to have about 25% of the population that's unprotected. So in this scenario, contact tracing becomes even more effective. And so right now, this is not the time to stop wearing a mask, not the time to relax in your personal mitigation measures. This is not the time to interact with other family members who have not been vaccinated outside of your family bubble. It's just not, we just don't have enough potential immunity in our community to do those things. And this is just a model that takes a look at what might happen over the next 200 days. If we don't fully vaccinate the population, we're going to leave about 100,000 people in Lancaster County susceptible to COVID-19, and which means instead of eradicating it or getting to very low levels, we will have a low endemic infection rate for a long time. And so it's important to tell your friends and relatives to get vaccinated, to continue all the mitigation measures. So in summary, schools are now being cleared to be opened by Penn Medicine and LGH. We've reached out to 18,500 contacts through our contact tracing program and have given quarantine advice to that number. On an optimistic note, the state travel order has been rescinded. So that was causing a lot of consternation. The CDC has guidance now for fully immunized individuals, and I referenced the website where you can take a look at that today. Pennsylvania relaxed restrictions a little bit on indoor dining and capacity limits. However, as I mentioned before, we won't continue to see declining cases unless our social distancing and other mitigation measures remain in place. We just don't have enough immunity in the population to stop doing mandated mask wearing at this time. The CDC has a nice graphic which shows if you have been vaccinated, who you can interact with. It's based on the risk of the people who are unvaccinated. And so that's very important. It's also important to realize that fully vaccinated residents who are in healthcare, non-healthcare congregate settings, such as nursing homes, do not follow this advice because the risk for them is so high that there's still a risk that people, even if everybody's fully vaccinated, they may get infection. And out in public, there has been no changes to the current mitigation advice, so please keep wearing a mask. So right now, schools can continue to inform your staff and about PA Department of Health and county updates. I think schools can continue, as they've done forever, to play a key role in limiting disinformation about the vaccine, about mitigation measures. You can be the voice of reason and science like you have always been. And I just want to end up by saying we're not out of the woods yet. We have a measurable way to go to get back to normal. And if vaccine goes as planned and we can get 70 to 80% of the population immunized, that's really probably not going to be until July, but hopefully prior to the next school year. But if we start to relax, it's going to be a longer haul if we don't continue those mitigation measures both inside and outside of schools. So thank you very much, and we'll take questions.
Great, Dr. Martin, thank you. We do have questions coming in. So again, just a reminder to our attendees, if you have questions for Dr. Martin, please post them on the Q&A section. So here we go. Should a person with a platelet abnormality, again, forgive me if I'm saying this incorrectly, thrombocytopenia, receive a COVID vaccine?
Yes, people that have a coagulopathy or are on an anticoagulant or have thrombocytopenia, which might make them more prone to bleed, can still receive the vaccination. If you're concerned, you can talk to your primary care physician about it. But what you'll want to do is identify that you have thrombocytopenia when you go to the vaccine site. One of the things that they can do once they administer the vaccine is to put pressure on the site, the vaccine site, for 2 minutes prior to you going to sit for your 15 minutes of observation. So people with bleeding disorders and other things still can get the vaccine, but you want to notify your person administering the vaccine that you have that.
And then the next question that's come in, I've already had COVID, so why should I get the vaccine?
So the issue there is that we don't know how long natural immunity lasts. In fact, there's a lot of concern that natural immunity doesn't last very long, manifested by the fact that about 50% of people after 3 months of having natural infection lose antibodies. And we still think there may be some T cell immunity there, so it's not all about the antibodies. But we just don't have enough information to know how long natural immunity is going to last. We do have good information that people that have COVID and get the shot, they have a boosting of their antibody response. And so we do think that having natural infection and a vaccine is probably going to be better than just having natural immunity alone. But only time will tell for sure.
And is there a time frame if you've had COVID as to when you should contemplate getting the vaccine?
So the CDC says you can wait 3 months if you want to after having natural infection. However, most people are saying at this point, because of the way the vaccine distribution is being rolled out, that if you get invited to get the vaccine and you're recovered at least 2 weeks post COVID illness and you're no longer having symptoms, that you can get the vaccine anytime after that. If you receive monoclonal antibody treatment, so the Regeneron product in an outpatient setting, the recommendation is not to get immunized for 3 months after you receive that antibody product because it could interfere with the immune response of the vaccine. But other than that, most people are saying if you get invited and you've been at least 10 days of COVID and your symptoms have resolved and you're at least 2 weeks out from the initial infection, that it's okay to get vaccinated at that time.
Would the vaccine or any of the vaccines affect anyone with epilepsy?
I don't believe so. I don't think there's any interaction that I can think of. I don't think seizures are actually, I don't know if they ever developed or we saw any of those side effects in any of the vaccine trials, but no, I don't. That is definitely not a contraindication for getting the vaccine.
And do you expect that we'll need to get a COVID vaccine each year?
Yeah, that's a little hard one to say at this point. It's possible. As I mentioned, most of the vaccines do show some activity against all the variants. So I think it's going to depend on new variants that crop up. It's going to depend on if there is a waning of immunity, for instance. But again, we won't know this unless we have more time behind us in order to research it and take a look at it. The good news with both the mRNA vaccines and the Johnson & Johnson vaccine is that if there does need to be a booster or a changing in that spike protein to match the mutations that are going around, circulating around the globe, much like what we do with the flu vaccine, that we can engineer those pretty rapidly. So the lipid bubble in the mRNA vaccines and the adenovirus vector for the JNJ vaccine doesn't need to be changed. We just need to change the encoding of that spike protein, and that can happen fairly rapidly.
And can you just share any other information you have or have heard about the possibility of a booster to kind of build on what you were talking about?
Yeah, it's really just a matter of it's going to depend also on how much COVID is going to be in our community. Again, I always keep saying this: the best way to prevent mutations from developing and from circulating, obviously, is to prevent from getting COVID. So the COVID-19 virus cannot mutate until it gets into a human host. And so if we knock it down to 0 or almost 0, then we're not going to necessarily see new mutations coming to the forefront as we've seen during this time, this third surge of really rapid infection and turnover. So if we can get the level of infection and community spread close to 0, I think we're not going to have as much of an issue related to new variations and new mutations.
And should we be concerned that the vaccines are not FDA approved?
They are FDA approved, but they're FDA approved under an emergency use authorization. Would I be concerned about that? I don't think so. They haven't really done anything different. They've had all the clinical trials. They've had all the safety data. They've put together, the experts that we can trust, that are the ones that are making the decisions about this. So the fact that it's under an emergency use authorization, or it is approved to be used under an emergency use authorization, doesn't bother me. That has happened a lot with many different types of therapeutics that we've used over the years. The FDA is clearly not going to put out something via an emergency use authorization without thinking about it and making sure that it's safe.
Do you have a sense of where all the misinformation and varying information and blatantly contradictory information is coming from, whether it's news, researchers, drug companies? Any thoughts you have on that?
Yeah, misinformation is interesting. I think that it's a combination of people who are kind of leaning against vaccines to begin with. They may reach out to something that they grab onto and use it to justify how they're feeling about vaccines. We just got a interesting letter that showed up at the Clinic for Special Children's doorstep down in Strasbourg. They treat some of the plain population who have rare metabolic disorders, but it was a photocopied piece of paper that's been circulating in the Amish community that says that Robert Kennedy says, do not get the vaccine. It is the biggest genetic experiment in the history of the human race, that it could damage people's DNA. And what's interesting is that Robert Kennedy Jr. never made any of these statements. He is not necessarily a fan of vaccines, but he never went so far as to say some of the statements that were in this letter. So I think it's a combination of people that kind of hear things and then they embellish and then they push it out. They use fear. Unfortunately, the Amish and plain population is a very susceptible population to some of this disinformation. I know that some of the social media platforms are trying to squelch some of the disinformation. What I would ask everybody to do is talk to somebody that you trust, not a Facebook post or Twitter tweet. If you have concerns, talk to your family doctor, talk to a relative that you trust, talk to somebody that you've gotten trusted and realistic advice in the past. Do not take what you see on social media at face value.
Another question: who or how is it determined which schools get invited to receive the vaccine and when? If you want to talk about the mass vaccination site first, and then I can certainly jump in with
Yeah, well, why don't you jump in, Mike? Because I know we're not so we're not giving any of the J&J vaccine at the mass vaccination site. So the schools all have their separate process. And Mike, you're probably closer to that than I am to say how that's happening.
Sure. So from the Johnson & Johnson or the J&J vaccine, all schools received a link for a survey. That link came from the state, which was passed through the intermediate unit. We were asked to send it out to our school district staff for all staff in the schools to sign up if those were interested in getting the vaccine. We then had to prioritize because every school district, public, non-public, were allotted a certain number of vaccines. That allotment was determined by the state. And we had to then submit our list based on the prioritization of teachers and staff with special education, English learners, elementary, and then working all the way through the school district. So not everyone who signed up was eligible in the first go around based on the allotment. And so our hope is that we will be getting another link shortly to send that out to staff who are still interested but have not received a vaccine, whether it's the Moderna, the Pfizer, or the J&J, to sign up. And then we will have to see what our next allotment is by school district. And hopefully, from what we've heard, that either by the end of March into the April timeframe, that all staff who work in schools who want a vaccine should be able to get one. That's going to be dependent on the supply from the state. Another question, how long will the side effects affect us from the J&J vaccine?
Yeah, so it's similar to the Moderna and Pfizer vaccines. They're usually 24 hours at the 48 hours at the most. They usually resolve spontaneously. Like I said, I haven't been seeing a lot of people that needed to necessarily take off of work for this. It's okay that if you have side effects that bother you, like myalgias, certainly fever, that you can take some Tylenol or Motrin. They're recommending that you don't take that prior to getting the shot, however. But if you do develop those symptoms afterwards and you want to feel more comfortable, you can take some over-the-counter Motrin or Tylenol. But again, they haven't been terribly significant. I mean, you're going to hear stories of some people that were knocked flat on their back for a while and had to take off of work, but that just hasn't been the experience that we've had so far here on the healthcare side.
Okay. I believe that's all the questions that have been submitted. We've gone through all of them. So I want to thank everybody for your time this afternoon. Dr. Martin, thank you for your time and for bringing this information to us. Again, we are recording this and I will send the link out to all of the school districts, superintendents, as soon as I get the link back, and then we'll be able to send it out to staff. And so again, thank you for your time. Thank you for joining us. Stay safe, stay healthy. And when we are able to provide another webinar of this educational format, we'll certainly send information out to school districts. Thanks again and take care.
Bye, everybody.